Hello, René Chapot. I'm the head of interventional neurology, working at Krupp Hospital in Germany, in Essen, for the last 18 years. So embolization has been achieved for years, had been developed some 40-50 years ago, but stayed for many years as a treatment allowing a partial reduction of an AVM. And since we co-developed the treatment of AVMs by the veins, it's possible to obtain a curative treatment. So this is a major change, and it's a major change as this treatment allows not only to treat the small AVMs, but also the very difficult large ones that are faintly accessible to other modalities, where some imaging modalities have been developed allowing to understand the AVM. The nidus are many vessels put together, but how to understand these nidus? The imaging modality that we call 6D allows to see how the veins come together, and once this is understood, it's possible to treat the AVM by the veins step by step once a compartment has been defined, and this is a major step forwards. It's a patient-based decision, knowing that from a principal point of view, open surgery is achieved from outside to inside, so that the more the AVM is superficial, the better it's accessible to surgery. The more it's deep, the less it's accessible to surgery. The criteria for embolization are somehow different, knowing that the deep veins are still more easily accessible than cortical veins, but there's certainly a certain amount of patients where both techniques fit. So I would say each patient-based decision is to be discussed, knowing that there is a third technique, which is also radiosurgery, which can be applied in rather not too large AVMs. The larger an AVM, the more functional the territory where the AVM is located, the more there is reluctancy to do a treatment which may harm the patient. So in patients that are poorly symptomatic, we are very cautious, knowing that on the reverse aspect, if a bleeding occurs in this territory, the patient will be severely harmed. So again, it's a patient-based decision, knowing that bleeding is an important factor to be considered, but since Aruba, it seemed that it has become the main factor. So a patient that has bled will be treated, and patient that did not bleed won't be treated. Probably it's excessive to dichotomize treatment of AVM only based on this criteria. The various strategies are either open surgery, radiosurgery, or embolization that can be achieved by different ways, transarterial, transvenous. In patients that won't be treated, symptoms can be handled medically, and one of the most frequent symptoms is epilepsy, where the intake of oral medication is a very good way to handle the symptoms.